Welcome to this session. We'll just give about 30 seconds for people to slowly make their way, grab a coffee while they walk down the corridors, switching rooms. Okay, let's make a start. Welcome to the organized session on the impact of payment models and training on provider behavior in China, organized by the Harvard-China Health Partnership. My name is Terence Cheng. I'm a research scientist of health systems and policy at the T.H. Chan School of Public Health at Harvard, and I'll be chairing this session. I'm delighted that you can join us today as we learn about recent innovations in provider payment models and training in China, and how these affected provider behavior, care use, and care quality. Today, we're delighted to have three young, early and mid-career scholars of the Chinese healthcare system presenting their work. So the proceedings would be that each presenter would speak for 8 minutes in turn, followed by discussants who will each have 5 minutes. At this point, I'd like to introduce our discussants who have very kindly agreed to share their thoughts and offer suggestions on the presenter's work. Our first discussant is Professor William Xiao, Bill. Often people call him Bill. Bill really needs no introduction and well known to all of you. Bill is the Katie Lee Emeritus Professor of Economics at the Harvard T.H. Chan School of Public Health. Bill is an international expert in health financing and one of the foremost giants of the Chinese healthcare system. Our next discussant is Professor Anthony Scott from the University of Melbourne. Anthony is also himself a global leading international expert on physician behavior. He has examined extensively how incentives affects physician behavior and performance, and done also extensive work on the workforce. I'd like to briefly introduce the context of the session, though I'll keep this very brief, to leave more time for questions towards the end after the talks. So the context is that China in 2009 launched a major reform of its health system, emphasizing both the expansion of social health insurance and also as well as improving the delivery system. And with the latter, it encouraged local governments to experiment with alternative payment methods. And today we hear some research that's done in this area. Another priority of the reform is the strengthening of the primary healthcare system that has traditionally been very weak and leading to patients visiting and relying heavily on hospitals. And again, today we'll learn a bit more about work that's done in terms of implementing in-service training programs to enhance the capacity and knowledge of clinicians. So without further ado, let me invite the first speaker. The first speaker is Dr. Hao Zhang from Harvard T.H. Chan School of Public Health. Zhang, all yours. You're unmute. You're mute. Can you unmute? Yeah.
Thank you, Terence, for the introduction. Okay. So the paper I'm presenting today is an impact evaluation of a global budget payment reform funded by the World Bank. So the background of this reform is China's healthcare system is suffering from substantial inefficiency. There is allocative inefficiency in the form of overuse of high-level hospitals, and there is technical inefficiency in the form of overprescription of drugs and tests at hospitals. And in rural China in particular, the problem is, as the country develops, rural patients want better care, but county hospitals, sorry, let me adjust the window. So county hospitals, while they're incentivized to compete under the fee-for-service payment system, they were not incentivized to compete with urban hospitals in particular. So rural patients increasingly use out-of-county hospitals with improved insurance coverage. The rural insurance is called NCMS. And the expensive OOC admissions put a lot of financial pressure on county NCM funding, but county hospitals don't really share the pressure, and they may actually exacerbate the pressure if they make up for the patient loss to urban hospitals by prescribing more tests and drugs to the patients they already have. So the question of this paper is, can we design a global budget that provide the right incentives for county hospitals to improve both allocative and technical efficiency? And what are the contextual factors that can enable the success of this global budget? So the project is called Approach. It designed and piloted a novel global budget in the province of Guizhou in China. And here we can see the global budget formula. It's a little bit complicated. Basically, it's a sum of diagnosis-specific budgets. So the D represents the diagnosis a county hospitals can treat in a given year. And the budget has two components. The first component tries to incentivize technical efficiency by paying admissions at a fixed diagnosis-specific price, represented by P. And the second component tries to incentivize allocative efficiency by rewarding county hospitals for retaining patients who would have otherwise had OOC admissions. And the global budget will pay them at the rate POOC. And the POOC is set to be larger than P county hospital, so that county hospitals don't have to worry that they may suffer financial loss if they retain the potentially more complicated patients. The projected number of admissions was set based on the number of admissions from previous year. So the first N is the actual number of admissions at county hospitals from year T-1. And this NOOC is the actual number of OOC admissions from year T-1. And the county hospitals are expected to retain a portion of the OOC admissions in the last year. And the share is represented by delta. It's larger than 0, but smaller than 1. So at the beginning of every year, 70% of this total budget will be prepaid to hospitals, and 30% will be withheld until the year-end quality assessment. And at the year-end, the total budget will be reconciled based on the actual OOC and county hospital admissions, because we can imagine the number of admissions for each diagnosis will fluctuate naturally. To determine whether a hospital underperformed or overperformed, we actually use the share of admissions at county hospitals versus OOC hospitals. So if, for example, if a county hospital is expected to admit 10, it is expected to account for 30% of admissions, but they actually accounted for 40%. Then that extra 10% will be considered as averted OOC admissions. And based on that, if a county hospital underperforms, we will claw back the overpaid amount. And if they overperform, we'll just pay them extra. We'll pay them extra money for the due amount.
How you have 3 minutes.
Okay.
Just advance. Thanks.
So the global budget is randomized to all rural county to all rural counties in Guizhou. We excluded 18 counties because of for various reasons. And during the implementation, 12 pairs, we had non-compliance in 12 pairs. So in the end, we had 32 counties, which is 16 pairs. The model we use is an OLS model, and we use randomization inference to calculate the p-values. We first examined the sample representativeness of our evaluation sample, and we find that our sample is pretty representative of the 74 rural counties in Guizhou province. However, the baseline balance suffered because of the non-compliance. The treatment counties were less developed due to some imbalance in urbanicity in 3 county pairs. So in our all regression models, we control for this imbalance by including a dummy for these 3 pairs. And the result on allocated efficiency is we find a significant decrease in the share of OOC admissions, and correspondingly a significant increase in the share of county hospital admissions. However, we don't see a significant effect on total expenditure or case mix index. And on technical efficiency, we find a decrease in average expenditure per admission and length of stay. However, we cannot estimate the effects precisely. And on quality of care, we look at the 30-day all-cause readmission to isolate readmission due to poor quality and readmission because the hospitals were just artificially inflating admissions by discharging patients and readmitting them quickly. To distinguish the two scenarios, we calculate same hospital readmission rate and different hospital readmission rates, and we don't see an increase in different hospital readmission rate, but we do see a small increase in same hospital readmission rate, which seems to be suggesting that county hospitals might be discharging but readmitting patients. And we also look at effect. We also did effect heterogeneity analysis, and we look at heterogeneity along treatment duration of the treatment and the share of revenue from NCMS, which represents the strength of the incentive. And we also look at the size of the hospital, and we also look at the management quality of the hospital. In general, we find that we find some heterogeneity by treatment duration, incentive size, and hospital size, but we don't really find a difference between better managed hospitals and less well managed hospitals. So to conclude, the contrast we find, the contrast between the significant improvement in allocated efficiency and insignificant improvement in technical efficiency might be due to the very complex incentives the hospitals face. And we think our results is an underestimate of the approach potential. And our study also illustrates the challenges in evaluating very complex interventions. So we call on the impact evaluation community to put together effort to develop alternative gold standards. Thank you.
Okay, thank you. Thank you very much. Let's go on to the next speaker, Hu Min from Fudan University.
Yes, thank you, Terence.
Yep. you want to put full screen?
Yeah, I know. Okay. Yeah. Is it okay now?
Yeah,
okay,
looks good.
Okay, thank you, Terence. Hello, my name is Zoomington from the School of Public Health at Fudan University in China. So on behalf of my colleagues, I'd like to present to you the preliminary findings of our study entitled The Impact of Hospital Internal Pay-for-Performance on Clinical Departments Health Services. So although pay-for-performance or P4P programs have been widely implemented in hospitals around the world, there is mixed evidence about their effectiveness. There is a particular lack of research studying the clinical department as a payment level. Most target hospital or individual level. So in China, there are great challenges to control healthcare expenditure. Things become more complicated when the structure of the healthcare expenditure is improper. In 2014, drug expenditure accounted for almost 50% of outpatient costs and almost 40% of inpatient costs. This is much higher than the average in OECD countries. Also, income from medical services accounts for a lower share in both outpatient and inpatient services in public hospitals, only about 20% of the total revenue. In recent years, a number of policies have been introduced in China aiming to adjust the structure of health expenditure, including raising the prices of medical services, as well as canceling the drug markups. These policies have given hospitals a stronger motivation to increase service revenues and decrease drug sales. Hospitals are also facing other policies, such as performance appraisal and global budgeting in Shanghai, for example, which incentivize the hospitals to improve quality and control costs. All these external policy changes prompt the hospitals to change their internal regulations and management. Some of the hospitals established internal performance assessment on clinical departments and linked it to resource distribution, namely hospital internal P4P at the department level. In theory, these incentives might further transfer to doctors in the departments to change their behaviors, the patient costs, and thus quality and efficiency of care. But the evidence is scarce, so we designed an empirical study to examine the impact of the hospital internal P4P program on service outcomes. So our study was performed at Hospital A, a large tertiary general and teaching hospital in Shanghai. Before the study, Hospital A rigidly used the drug costs and the consumable costs, both absolute value and the percentage, as cost assessment indicators to control healthcare expenditures. Clinical departments would be punished by deducting bonus when exceeding the targets. Thus, most of the departments focused on costs instead of patient outcomes. However, expenditure remained difficult to control as physicians might increase other costs, for example, examination, and increase times of prescription. Also, physicians had no incentives on quality improvement. From August 2018, 19 out of the 40 clinical departments in the Hospital A started to implement a P4P program. So departments were awarded with extra bonus by making higher contribution of service revenue and were punished if they conducted irrational prescriptions. This might potentially incentivize doctors in the department to pay attention to quality of care and the rationale of drug use. And so this slide shows the comparison of the programs between the intervention and the control groups. Here is the description of the characteristics between the intervention and the control groups. Statistically, there were no significant differences between the two groups in terms of number of beds, number of outpatient clinics, number of staff, and department type. And also no difference in risk index, which is an indicator reflecting the difficulty of diagnosis and the treatment in the department. So we used difference in difference analysis to estimate the impact of the P4P program on monthly health service outcomes adjusted for covariates. Our four main outcome domains, which were measured monthly, were inpatient drug prescribing, that is the prescribing rate of adjuvant drugs and antimicrobial drugs. So the other one is the inpatient cost structure, which are the average inpatient drug, consumable drug cost per visit, consumable cost per visit, and examination cost per visit, and the service cost per visit. And also we checked the average inpatient costs per visit, and also the service volume. So we first looked at the period 1 year before and 1 year after the P4P was implemented for all the outcome indicators. Here, for example, are the cost of different categories. So we saw that those four outcomes show different trends after the P4P was implemented. To check whether the
We lost you.
Yeah, Humin. So I wasn't sure if it's my internet or was it on. Let's wait for Humin to come back. Let's give her some time to log back in. So in the meantime, while we are waiting, we just give her a minute to log back in. While we're waiting, if you do have any questions that you'd like to pose to the presenters, please feel free to put these in the chat, and to presenters as well, kind of monitor the chat, because there are already some questions for Hao Chang. Okay.
Perhaps you want to take some questions now while we wait, or you want to have the discussant start discussing Zhang Hao's paper before Humin can come on.
Yeah, I'm actually inclined to go on to the next speaker, and then Zhang Hao, Humin can come back to finish up her talk. I'm not sure how long she would take to come back. Is it okay that you go on to your next talk? I'm just not sure how long Humin would take to log back.
Humin, she hasn't been able to log back yet. So,
okay.
So we should either go to the third speaker or start some discussion.
Yeah. How can you present, and then we'll kind of route back to Humin later.
Sure, I can start my present.
Thank you.
Can you see my slides?
Yes, looks good.
Yeah.
Thank you.
Great. So I'm Hao Xue from Stanford University, the Stanford Center on China's Economy and Institution. Today, my presentation will talk about random control trials of impact evaluation on in-service training program for village clinicians in rural China. Our team, including Hongmei from Peking University, Shang Xiu from UNC Chapel Hill, and Scott Rosell from Stanford. Starting from 2009, there's multiple reforms and government policies focused on improving the quality and efficiency of primary healthcare in rural China. However, our studies in 2015 shows that using standard patients shows the quality of rural healthcare is still very poor, including low computation checklist, diagnosis, and low correct medicine rate. Thus, it seems like the successful of continued reforming depends really on the quality of primary care providers. Then how do we want to improve the quality of primary care? Usually there's three ways. First is to train new doctors and extend these new doctors to work in rural areas. However, it already proved like very hard all over the world. The other way is to provide the support from the upper levels, including county and township physicians, and maybe some resources, remote resources using digital technologies. Now it's kind of popular way to do that. The last, but which is also the most common ways to improve the quality of existing village clinicians. However, previous study already showed there's low level of knowledge, which means like the training may improve the performance, but on the other side, there's maybe a gap between what they don't know and what their practice. However, we didn't find like a very solid evidence on the fact of training the communications program like in rural China. What we do is we launched our random control trials to evaluate an impact training program in Yunnan province. This is the baseline start from 2017. After 3 months, the doctor received the training, and after 3 months, and 3 months later, we did the evaluation. In total, there are the 330 clinicians. We randomly select 1/3 of the clinicians into the treatment group, and the others in the control group. The Red Cross provincial Red Cross provide a 15 days of training program covering a variety of topics, including theory-based and practical-based training sections. We mainly use two types of measures. The first is the clinical vignettes, which measure the clinician's knowledge. We use the diseases match the content of the training, and there are 3 diseases: asthma, angina, and diarrhea. Also, and here, when we're doing the clinical vignettes, the doctor knows that they are being tested, so they try to perform the best of their knowledge. After that, we use announced standard patient, which is people prevent a patient and visit the village clinic. We try to test their actual performance when they do not know that they are being tested. These cases, we use the identical cases in the vignettes, so we can match the results. And what we measure here in both vignettes and standard patients is we try to measure the adherence to the national and international guidelines, including the process, diagnosis, and case management. So what are the results on the, we will first let's look at the results on the knowledge. The blue line is the treatment group and the red line is control group. After 14 weeks after the training, there's we can see the knowledge in the treatment group is a little bit higher than the control group. This is already adjusted for the baseline. However, we want to say that only for about like 50% of the doctors attend the training, and there's no significant difference between the significant correct diagnosis and case management before the treat and control group. This is the knowledge. When we look at the practice, the using standardized patient, there's no difference practice. Even when we look at the ITT effects or the local local effects, marginal effects, which means the increase in knowledge does not translate to any better performance. Then we want to know like what happened. Is this because there's any like limitations on the facilities, equipment, so they cannot do this, or the medicine story because they don't have medicine, or because there's kind of incentives between that. So we try to use the know can do gap model to analyze this. When we compare the knowledge they know and what they can do given the facility, equipment, and medicine storage. The other gap is like what they can do and what they actually do, the performance given their like current incentives. We can see like those nodal gap, we see the increased knowledge but didn't translate to the performance, mainly contributed by the what they can do gap beings, which is caused by the mid and low and maybe misleading incentives. They know how to do this, but they just didn't do that. Additionally, we tried to do some heterogeneity analysis to see which group is the most benefit. We use the coral forest like by Susan Enshi and Weger to try to provide a causal inference on the impact on subgroups. If possible, we plan to provide some insights for policies if they with like limited resources only target on the groups with the most benefits. So what we do is first we compare the groups with the with impacts in top quantiles and the others. We can see if we only look at on the impacts, it seems like this is a difference of the top quantiles and the rest of sample. There's difference on the impacts, both in like the 3 dimensions we measured. However, when we look at the top quantiles of the characteristics, including facilities and provider characteristics, we didn't find the very consistent, like what types of clinicians really benefit from the program. So the final takeaways is we find that those kind of like on-site training have kind of a small impact, increased knowledge, and maybe works for the some subgroups. But there's a lot of room to improvement. The take up the role, the improved knowledge didn't translate to the better performance, and we didn't find which is the most benefited subgroups. So the next question is, how do we want to improve the training? Maybe from using more digital resources, or should we focus on the incentives performance? Thank you. Therese, I think you are unmuted.
I would have done this many times. Still, I'm still muted. Let's go back to Humin to finish the talk. Humin, you should have sharing rights out. Good, yeah.
Can you hear me?
Yes, all good.
Okay, yeah. I'm very sorry for the trouble. So shall I start from this slide? Okay. So is it the slide that I got when I got offline? So I
yes,
think so.
You can start
okay.
From here.
Yeah. So to check whether the intervention and the control groups were parallel, before the P4P was implemented, we performed a trend analysis and we found that they were parallel for all of the outcomes. However, after the P4P was implemented, there was a significant decrease in the use of antimicrobial and adjuvant drugs for the intervention group compared to the control. Also, the inpatient cost structure changed significantly in the intervention group with lower average drug cost, but higher average cost of services. And the average inpatient consumable cost also increased significantly. So after the P4P was implemented, we saw no significant changes in the volume of services, nor of the average cost per hospitalization. So to summarize our preliminary findings, the specific P4P program we studied reduced the average inpatient drug costs per visit by approximately 20% and also increased the average inpatient service cost per visit. And the P4P improved inpatient prescribing practices. So we concluded that implementing the P4P program at clinical department level encouraged doctors to provide services beyond the prescribing drugs. And however, the P4P program may induce unintended outcomes such as increased consumable costs to compensate for the reduced drug costs. We also have some limitations for the study as we only studied in one single center. Also, we could not avoid the interactions between the intervention and control departments. And we didn't have the chance to observe the quality indicators in terms of patient outcomes. So that's all. Thank you very much for listening.
Thank you. Let's go into the discussion session. Bill? Bill, you're unmute. Yep.
Yes.
Hu Min, can you uncheck? Yes, all good.
Thank you. I thought those are three very interesting and very innovative studies evaluating some innovative interventions. I'm going to concentrate, just make a few comments on Zhang Hao's because she's right here. I can give her more comments later, but I will focus mostly on Hu Min and Xie Hao's paper. For Zhang Hao's paper, I would suggest you make clear what is the time period you measure the changes of hospital behavior, because you're trying to use incentives to alter their practice and behavior, and but we know changing behavior takes time. And the second part I thought the study missed is how did the change in allocative efficiency or technical efficiency affected health outcome? I would like to know, you can be more efficient, but is there a trade-off with the patients? And third but last is that how did the hospitals induce the patients to stay at the county level rather than go out the county? And because that will be important, because you're measuring utilization, and that's the result of interaction between supply and demand. But then let me focus on Hu Min's paper. I think that's really a very important and interesting study. I really hope that will encourage other researchers to probe this question. Namely, when we design policy, we change the, let's say, the payment or regulation, and we're trying to affect that black box, which is the organization. And we acknowledge that's the black box, and but we assume we measure the outcome, which is the results of the performance by individual physicians and practitioners. Here, Huming's study trying to open up that black box for us, and by saying, okay, under P payment, how did the hospital change the criteria, how physicians may be measured and observed on their clinical practice, and one is on drug prescription, and then she also measured the cost of services. And so my comment is, so my first point is, this kind of study is really important, and it's missing, as far as I know, in health economics. There are very few of these studies, and so I commend you open up that black box, and that to me is the frontier of new research. But the second part is you're focusing on the clinical departments. That's correct. However, you focus on just the financial results or the bonuses they get. I would urge you to look at non-financial incentives. Like, you know, the Chinese hospitals really use promotion, using other non-monetary rewards to hold you as the best worker of the month and that kind of thing. And I'm sure that makes a big difference. So my time is up. I'm sorry. I would send my comment to Xuehao independently. I like what you have done, but I thought your sample is too small, and also your do gap missing one key point. We know Chinese. First, I'd like to know what kind of practitioners you were training. Are they the village doctors or the 3-year medical school graduates or regular doctors? Their behavior and what they do and learn, I think, will be different. Second, we know, I make a generalization, Chinese doctors, through the systems mistakes made by China, we know in general Chinese doctors' incentive or goal is to make money, generate revenue for their organization or for themselves. And so you can change the knowledge. I would have, without changing their incentive and reward system, I would have predicted you won't have made any difference on their behavior. I'm sorry, I'm running over time. I can send you my other comments.
Thank you, Bill.
Thank you.
Tony?
Thank you. Look, I enjoyed these papers, and I always love looking at these papers coming out from China, because the scale of reform and the types of reforms that are happening are just usually large and quite exciting. I think in a lot of countries where you know, we've had developed healthcare systems for a long time, we're often operated at the flat of the curve, whereas I think in China, particularly in other countries who are, say, just beginning to introduce insurance, but also changing payment models that were well below the flat of the curve. So you're going to see bigger and more interesting effects. I think there's a couple of comments just generally across all three papers. I guess just echoing Bill's comments on the black box of organisational change, and that's really important because often with these interventions, other things are going on as well. With pay performance, there's often quality reporting going on separately to pay for performance, which can have an independent effect. It's often very difficult to disentangle these. But it also means that, I've done, I think, 3 different reviews, systematic reviews of pay performance. And one of the things that I come across is that trying to dig information out of the studies on what actually happened is actually quite difficult. There's obviously no standardized reporting of the interventions. There's very little standardized reporting of the comparator. So what things were, or it might be fee for service, but that can cover a lot of different things. And often, I guess, with word limits, it's very hard to kind of do that. But it is important to kind of be very careful how you report the interventions so we can compare them. And also, I think across 3 papers, it's important also just always emphasize what you contribute to the literature. There's a lot out there, and systematic review on pay performance comes out every week just about. So, it's kind of what are we really contributing here for some of these payment model evaluations. So a couple of details on the specific papers. So in terms of a Hao Zhang paper, I think it was a great study. It's really fascinating how you did the randomization, and then also in any good randomization things don't work as well as you planned, and people drop out and counties drop out, and I think the way you handle that was good and very important. I wondered, because you randomly paired counties and then randomized them, and the pairing was done on kind of matching, and I just wondered about adjacent counties and people moving across borders, and whether that was an issue in trying to make sure that these effects are kind of independent from your treatment and controls. I guess you had 2 waves of the rollout as well, which was interesting, and the treatment effects, I think you said, seem to be similar across, but were the hospitals in wave 1 versus wave 2 randomly selected, or were there some reasons why some hospitals went first and others went second? And also, with people dropping out, then you can't, or people not, conforming to the intervention, you can't really use intention to treat analysis, and then you have to rely on other methods. So your randomization is compromised, and that's always an issue. I think you deal with that reasonably, but there may be other kind of methods you can use to try to think about that. And I did think about, how would you think about, in your context, of how would you have done a sample size calculation to begin with, because it's quite a complex kind of randomization process. Yeah, so I think those are the main issues there. I thought it was a really great paper, and I enjoyed reading it. And also, I guess one last thing, in terms of the randomization inference p-values that you used, I hadn't come across these before, so that was quite interesting. But also, just a explanation, and maybe this is better for the paper, as to why you use these in your particular context. Would be useful. Okay, so in terms of Minhu's paper on paper performance, I guess you're right in terms of looking at the clinical department is important, because a lot of hospital paper performance schemes, payment to the hospital, and you really don't know what happens after that. In the studies, it's hard to find out what happens after that. So again, when payments go to the department, even within the department, then what happens? You know, what's the organizational change in the department that kind of leads to a change in behavior, change in spending, or change in quality? Obviously, these payments, you know, you'd think have to affect the clinicians and doctors somehow. How does that happen? How do they change their behavior in relation to that? And that's an important thing that's often missed in these studies, but quite important. I think in terms of your kind of spillovers between departments, I wondered if you could maybe look at that by thinking about patients who move between hospital departments. So we might have surgery and then move to a medical ward, and the surgical department might be incentivized, the medical ward might not be, or vice versa. So, you know, for those patients who are movers between these departments, can you use that to try to help, you know, identify what's going on, or at least test whether that was a problem or not?
Tony, could you wrap up in 1 minute?
Yes, sure.
Thank you.
And so that was the main thing there. And then with the Haoju's paper, again, there's, you know, it's one of those other interventions that go on in terms of upskilling and training the clinical workforce. You know, there's not a lot of randomized trials out there generally about training doctors, surprisingly. But again, you know, the study again suffers from a bit of selection bias as doctors in training drop out. I was wondering about the power calculation, sample size calculation, and again, I wasn't sure what the no can do gap thing was, but that may just be because of the time constraints. So, but 3 great papers, and address lots of common interesting issues. It's always amazing to find out what's going on in China. So it's always very exciting. Thank you.
Great, thank you. Lots of food for thought by both Bill and Tony. We do have some time for questions. We've got 8 minutes before the session draws to a close. Any questions that the audience might have? Or this could also be a time where the presenters can also respond to some of the comments if you would like to, or if there are kind of 1 or 2 important comments that you'd like to kind of respond to, you can also do that. So any questions from the audience? No, it's either too late where you are or too early where we are. Winnie, would you like to?
I have a sort of a comment or reflection, especially for the first 2 papers. The intervention that you describe is actually rather complex. Maybe less so for Shanghai's paper because it's mainly training. I want to ask both authors to reflect a little bit on whether this sort of difference in difference is the optimal methodology to try to get at the richness of the intervention and what might have happened that might explain your finding or non-finding. So that's my question for the first 2. For Shanghai, I am curious, before going into the intervention and analysis, what did you expect? Did you expect to find result much positive impact of training? I mean, this goes to Bill's comment a little bit, but even looking at the literature, I mean, I know that India actually has done quite a bit of these kind of studies, and there is some debate a few years ago on whether training is useful or not. So I'm just curious about how you thought about it, why training is something you want to study, what motivates you. And then for Humin and Zhang Hao about given the complexities of the intervention, what just a reflection of whether difference in difference, which I have now always called a dummy approach, that is subsuming everything into a dummy variable, is what are you missing? What might be the alternative that you would want to know from the very interesting intervention itself?
I think I want to provide a very quick response on the expectation of the training. Honestly, our original design was the 2 steps. We train 1 step of doctor only for the training, and we expect some of the increase on knowledge, but maybe not the performance. Actually, we plan to do a second round of interventions, including the just training and some kind of like incentives or like performance interventions. However, due to kind of like very complex reasons, we cannot do the second round of intervention. So we have to like really think hard what is the contribution compared to like in India, they have a science paper on the village doctor training. So we try to provide more insights. For the example, we try to use like the causal Fourier to learn like what is the subgroup like effects on subgroups, or like what can we really learn about the mechanism why it does not have like impacts on some of the village doctors.
Right. Okay. I see Bill has unmuted. Do you have a point that's relevant to this? No.
I had a chance to speak.
Yeah.
Parents, if I can.
Yes, that.
Yeah, I noticed that there was a question that I actually share from Zoomington regarding the approach and how it identifies an out-of-county patient. But so I'd be keen to hear that as well to Hao Zhang. And also in that particular paper, and all 3 were fantastic. So thanks so much. And I'm working on a project in Yunnan as well, so I was very interested in that one. But with the approach, I also wanted to check, how do you account for the fact that the patients might be choosing to bypass and go to the prefecture hospital? Often if you're using payment incentives, you use it for things that are completely in the control of the payee, in this case the hospital. Is the choice to stay at the county hospital completely in the control of that county hospital, I guess is my question.
Should I respond now?
Yes.
So I just give an example in the chat about how to calculate the how to decide if a county hospital achieve the target. As to your second question, so no, the hospitals, the county hospital physicians don't have full control. However, I think the point is not to completely eliminate OOC admissions. It's to provide incentive for county hospital physicians to try to retain more patients. Because before, under fee-for-service, they don't really have a strong incentive to try to avert OOC hospitals admissions. And now they do have an explicit economic incentive to do so. And this will marginally increase county hospital admissions and reduce OOC admissions. And in the long term, the goal is to incentivize county hospitals to increase their medical competence so that they can treat more diseases and provide better treatment so that patients are willing to stay.
Thank you.
Okay, we have 1 minute left. Anybody wants to? Umin, do you want to?
I just want to feedback to Winnie's comment. Yeah, I think that dummy variable for the DID is not enough for us to explore the internal inside of the hospitals. So I also thanks for Professor Xiao for his highlight on this kind of research is very important. And so when I studied in this is actually the first time for me to explore the inside in the hospital. And I think that the things are very complicated. So actually, I am only covering part of the P4P programs. So the whole program is very complicated. So I think I hope that I can study more on this program and can report to you all next time. Yeah, thank you.
Okay.
Can I just say,
Yeah,
just
totally.
quickly, there was a paper 1990 by Jerry Hurley from McMaster University called The Many Meanings of Money, and it provided a framework for analysing the impact of changes in funding models, which kind of interviewed people about how messages about the policy were communicated down and how miscommunication can lead to unintended consequences in their particular context. So it's an old paper. I don't know if it's still around, but it was useful to try and get at that black box from a kind of behavioural perspective.
Okay, thank you.
Great. On that note, I think we should draw this session to a close. On behalf of the audience, I'd like to thank the presenters for sharing their work, and a special thanks to the discussants for offering presenters much food for thought. Thank you very much for attending this conference, and join the remaining of the conference, and have a great day or great night, everyone. See you.
Thank you.